I'm Joelle. I'm a nurse. I work in NICU and postpartum. I have no disclosures. This was prepared to be given at the ANN meeting earlier this spring on Maui. So we're going to talk a little bit today about the Hawaiian people. And I invite you to join me in paying respect to elders past, present, and emerging. Infant mortality among Native Hawaiians is almost 3 times that of the general population. And this is not due to some flaw in their genetic makeup. This is a direct result of experience of trauma related to invasion, occupation, and cultural genocide experienced by the Hawaiian people. Healing this trauma and a return to traditional practices has been identified as a piece of the solution to rectifying these health disparities. Before we dive in, I want to take a moment to talk about language. The language we use not only shapes our own thoughts, but it signals to the world how we think and feel about people who use drugs and their children. I'm going to use the term neonatal opioid withdrawal, or NOW, because it's precise and non-judgmental. A problem with neonatal abstinence syndrome, or NAS, which is the word we typically use, is that it's imprecise. And a lot of people mistakenly wind up believing that it refers to withdrawal from other classes of drugs besides opioids. For example, in one hospital, I cared for an infant who was we created a dependence on opioids after this baby was not exposed to anything other than stimulants during pregnancy. And he ended up staying in the hospital for several weeks and having a hard time getting off of his brand new opioid habit. When we're talking about these babies, we don't say that they are addicted. Addiction is not a medical term and hasn't been for several decades. Way back in the 70s, when it was a medical term, it referred to a series of behaviors that cannot be exhibited by infants, such as drug seeking and neglecting responsibilities. So we refer to these infants as having a physiological dependence on benzodiazepine, or being prenatally exposed to cannabis, or experiencing withdrawal from opioids. We also don't use the terms addiction or addict or abuser to refer to their parent. We talk about somebody either with physiological dependence, problematic substance use, or a substance use disorder, as defined by the DSM-5. So neonatal opioid withdrawal is not fully understood. It's difficult to predict and not dose dependent. So that means that there's something else in there that's influencing the severity and which babies will actually exhibit signs of withdrawal that are severe enough to require treatment. It's also important to remember that this is temporary and treatable, and that these babies do just as well as their peers in the long term. So what is it exactly? For the most part, it's pain. And this pain is mostly gastrointestinal pain. We also see a hypermetabolic state, so that's going to be increased consumption of oxygen and nutrients. And you're also going to see a faster heart rate and breathing rate, which, as we know, blows off a lot of fluids. So you're going to need more fluids than necessary otherwise. We're also seeing neurological irritability. So that's going to be your hypersensitivity to noise, light, and also your jitters, your sneezing, and if left untreated, can lead to seizures. So neonatal opioid withdrawal leads to all of the signs on the right-hand side of the screen. We get that dehydration from the hypermetabolic state. We get failure to thrive from both feeding difficulties related to pain and hypermetabolic state. Increased muscle tone related to pain. Loose stools are a classic sign reported by adults as well when they're having withdrawal from opioids. Skin breakdown is going to be in 3 main areas, which all need to be prevented and treated slightly differently. Your bony prominences, that's going to be elbows, chin, things like that, and that's caused by rubbing against the clothing as the baby cries or just with jitters. We're also going to see intertriginous breakdown if the baby is not kept comfortable and cool. So that's mostly going to be in your armpits, sometimes groin and other areas, but that's from when the baby gets sweaty and so it's damp and lots of rubbing going on. You can get fungal infections in those areas. And then we're going to see perianal breakdown, which is part of life for most babies at some point or another, but can be increased for this population due to those loose stools. Tremors related to neurological irritability and upper airway congestion is also a classic sign of withdrawal in adults as well. What most of us are familiar with is Finnigan scoring. It was developed in the 1970s by Loretta Finnigan, whose glorious photo is right over here. And it's kind of a complex scale. There are 31 items, some of which are objective, like how many hours did the baby sleep? That's not easy to argue about that. A lot of them, however, are subjective. For example, what is an excessive cry versus a normal cry? What's a hyperactive versus a normal Moro reflex? It can be really difficult to get all of your staff on the same page and scoring in the same way on these items. Another issue with this tool is that you give scores for a lot of typical behaviors. If anybody's ever taken care of a newborn baby, you know that they sneeze kind of a lot, especially as they're clearing their secretions from those upper airway passages in the beginning few days. We also see mottling quite frequently, especially in babies with fair skin. In order to get an accurate Finnigan score, the baby must be observed for the entire interval. You have to be able to tell the difference between sleep and just a quiet state in order to score the sleep accurately. You have to catch every sneeze and every yawn in order to score those items. And this made a lot more sense back in the 70s when Dr. Finnigan developed the scale because we had open bay NICUs where infants could be observed the entire time. But now, as we move toward family-centered care with private rooms and central monitoring, it's not possible to count how many times the baby yawns in the interval from when you feed them to when you next feed them. This tool is intended only for full-term infants. And part of that reason is because a lot of the things that we associate in our minds with opioid withdrawal are actually just general pain and discomfort signs. So when we see poor feeding, tremors, respiratory distress, these are normal preterm baby behaviors and can be late preterm behaviors as well. So it's very difficult to tell whether you're scoring for just general pain and discomfort, prematurity, or opioid withdrawal. Because of these and other things, there's a lot of inter-observer reliability challenges. So the same two nurses could look at the same baby at the same time and come up with scores that are just widely different. Loretta Finnigan and Karen D'Appolito put together guidelines for how to do the score to improve inter-observer reliability. It's very important that your facility have a policy outlining how the score is done, when the score is done, and what is reportable. Finnigan and D'Appolito recommend reporting scores of 8 3 times or 12 2 times. You can also report the average of 3 scores as larger than 8. So for example, if you get 6 and then 9 and then 11, that counts as 3 greater than 8 or their average greater than 8. You can also report if the parents or if you just feel that the baby is deteriorating and needs some help. Very important to score the infant when fed, changed, and calm. If your baby gets too sleepy towards the end of the feeding, it's okay to do the score at the first birth break, for example. We'll find that any baby, whether they've been exposed to opioids or not, if you try to score them when they're hungry and they have a dirty diaper, they're going to score high. And that's just because of general discomfort. It's important to feed these babies on demand and not on a schedule. So that means if they're sleeping for 3.5 hours, that's okay. Let them sleep. If they wake up after 2.5 hours and they want to eat, don't make them wait. It's okay to give the medication at a different time than you do the score or at a different time than the feeding. If you have a tube, you can just put the medication in their tube as they sleep. Or if the baby's bigger and not preterm, you can give it a little bit at a time with an oral syringe in the corner of the mouth without disturbing their sleep. You can help the next nurse coming on if right before shift change, you chart what happened during your interval as far as sleep, sneezing, and yawning. So for example, if I'm coming on at 7 and the baby's due to eat at 8 o'clock, I have no way of doing the score for the previous interval because I wasn't physically present in the hospital during that time. So it's important to help out the oncoming shift that way. For a few items, it's also important to designate whether you're scoring for the current or the next interval. So for example, if you feed the baby, do the score, put them back down, and 10 minutes later they have a regurgitation, does that count for this score or does that count towards the next score? So it's important just to make sure everybody's on the same page. It's not so important that it be a certain way, but just pick one and stick to it. There are a lot of ways that inter-rater reliability can become messed up, but I'm just going to talk about these 6 items due to time constraints. For sleep, you need to score the longest interval of uninterrupted sleep. So that means if the baby sleeps for 60 minutes, wakes up and fusses for 20 minutes, you change the diaper, they go back down, sleep for 90 minutes, you score sleeps less than 2 hours. Even though cumulatively they slept for most of that interval, you only score the uninterrupted sleep. It's very important not to score if the baby is awakened by the parents or by us. We're trying to score things that come from the baby, not things that are externally imposed by caregivers on the baby. For tremors, you score 4 for the whole limb tremor without handling. And without handling means that you have not touched that baby for at least 30 seconds and they're calm and not crying. Increased tone is one that I see so much variation between different nurses. It's very important that everybody's doing this exactly the same way. So the preferred method is the lift to sit. So you grab the baby's hands and lift them up. And what increased tone would be if the arms are still bent and tight, even when you lift them up, and the head is still up. Now, just about every baby is going to bring their head up with them at first, but for most of them, after a second or two, the arms straighten and the head droops. So make sure that you give your baby enough time to demonstrate whether they're going to do that or not. Excoriation is referring to those skin on skin or skin on blanket areas of rubbing. It's not for perianal rash or breakdown. Fever needs to be clearly defined in your policy. Regurgitation is another difficult one to get people to agree on. It's important to remember that every baby sits up. Regurgitation is not sit up. Regurgitation is effortless, like the baby's just sitting there and whoop, they just erupt, kind of like a kid's volcano science project. It doesn't count as regurgitation if it's elicited by us. For example, if you're holding the chin and slapping the baby's back and they have a regurgitation, that's externally imposed by us and not coming from the baby. An emerging best practice that I'd like to talk about is eat, sleep, console. Some people call it eat, sleep, gain. And it gets rid of all those subjective issues with the Finnigan, and it also creates less work for caregivers because you're not having to assess 31 items. You just ask 3 questions. Can the baby eat? Can the baby sleep? Can the baby console? And this is going to help with communication between nursing staff and providers as well. And that's because you can get a really high score when the baby's actually doing very well. So you can score for, sneezing and muscle tone and a few other things, loose stools, and you can get a score above 8. But if the baby is sleeping 2 to 3 hours between feedings and able to be consoled and eating adequately to gain weight, I don't really care about that high score, and neither does the provider. So this is really going to help to streamline communication. So in order to implement this, it's quite simple. The most important thing is you have to partner with parents and families. So it's necessary to do a neonatology consult either before the birth or as soon as possible afterward, both to set expectations for what parents should look for, what their baby's going to be like for the next couple of weeks, and also to provide teaching and let them know how they can help and what they should ask of their family and friends and support people. So for the eat item, we need to make sure the baby can chest feed or breastfeed well or take adequate bottle volumes. And you can consider a nasogastric tube if the baby's unable to gain weight. For sleep, they need to sleep at least 1 hour between feedings. And for console, they must be able to calm down within 10 minutes. If after that you're still unable to console, then a dose of medication is indicated. One of the biggest differences between Finnigan and Eat, Sleep, Console is that scheduled round-the-clock medication is not the norm and is only indicated in most severe cases. Giving medication only when the baby needs it and not around the clock has been very helpful in reducing both pharmacological requirement and hospital stay. As I said before, parents are easily and by far your most valuable treatment tool. Often when I'm caring for babies, I realize that the things they want most are the things that I cannot provide to them as their nurse. They want skin to skin care, they want breastfeeding, and they want to be picked up right away when they cry. And they don't want to have to wait until I'm done feeding this other baby down the hallway. And those are the things that parents can do for you. And so parents should be valued and treated like gold by nursing staff. The way to get your parents to help you and to decrease the length of stay and make those babies more comfortable is to provide an environment that makes parents want to come back or want to stay. Uh, so many parents have guilt and shame about their substance use, and they feel that they're being judged when they come into the NICU. So make sure that when this family walks in, every staff person greets them with a smile and says, "I'm so happy that you're here," because that can make all the difference in the world. A lot of families are going to need services and support in order to be in the NICU all the time. Many people who are taking prescribed methadone are required to go to the clinic every single morning, and that can be quite difficult if it's far away from the hospital. People also just need their most basic needs taken care of. They need meals provided or somewhere to store food. They need somewhere to take a shower, somewhere to sleep, and they need some privacy. Other treatments that you can use with or without parents tend to fall into two categories: preserving energy and promoting comfort. So to preserve the baby's energy, the timing of your score is very important. The only thing you're waking that baby for is because it's time to score. Do not do it. And of course, or after feedings. Some babies might need high calorie feeding, so 22, 24 calories. So sometimes you need a lower volume of a higher calorie feeding. With all preterm babies, but particularly this population, you need to limit the total feeding time so that they don't spend more energy getting the food into their belly than the food is worth. So about 30 minutes. That means you chest feed for 10 to 20 minutes, and then you spend the rest of that time on the bottle to make sure that they're getting adequate volumes and adequate nutrition. Every time you get a regurgitation, you've lost a big chunk of your feeding. So it's really important to birth these babies gently to avoid that regurgitation. I don't use the typical chin support slap on the back method for these guys. What I'll do instead is wrap them really tightly in a C position and hold them upright close to my body and just gently rub their back. To promote comfort, we all know this one, tight swaddle. If your baby is really hot or sweaty or they've been scoring high for that, you can uncover the feet while after the baby's calmed down and sleeping in the bed, and that will help keep them from getting overheated. A cool, dark, quiet room is going to help with overheating and also with that neurological irritability. Sucrose should only be used for painful procedures for all babies, but especially for these babies. When your main complaint is stomach pain, sugar is not the answer. This is like if your toddler was running up to you saying they had a bellyache and you keep giving them candy bars. Sure, it's going to make them happy in the short term, but in the long term, it's making everything worse. Cuddle volunteers can also be really helpful. Not all hospitals have these programs, but I highly recommend them. You can have volunteers day or night, and they can just provide a warm, breathing chest and a heartbeat, which is all these babies want. Skin protection is something that you can also do. You can prevent some of that breakdown. So if you see a bony prominence getting red, you can put a hydrocolloid barrier over the area, such as Replicare or Duodral. Please don't hesitate to reach out to me for questions about this presentation. I can provide a more robust bibliography. I can provide policy templates, And I just love to talk to people about this topic. I never tire of it. So please don't hesitate to reach out. Thank you.